Good morning, good afternoon, or good evening, depending on where you're tuning in. My name is Allison Stroud, MR Marketing Manager for Philips Healthcare. I'm very proud to present to you today an exciting webinar that we've organized with the Technical University of Munich. TUM is a world-class university hospital that is forging close links between medical care and research. They have a focus on rapidly incorporating the latest scientific discoveries into modern medical practices. And this is greatly impacting their patient care and treatment pathways. In the past year, TUM has begun utilizing the latest 3T system from Philips, the 3T Ingenia Elation. Today, you will see more about how TUM is utilizing this system in combination with Compressedsense to accelerate and even add additional diagnostic imaging to their routine practice. You will also hear about the Philips unique touchless patient sensing camera called VitalEye. But I don't want to give it all away. So it is my honor to introduce you to three radiologists who can tell you a lot more about what they've been doing on this exciting new system. During the presentations, you will also be able to send questions to the speakers in the Q&A box at the bottom of your screen. We will then address some of your questions at the end of the webinar. Also, we would love to hear some feedback from you at the end of the talks, so please stay tuned for that. Please just follow the link to take part in our brief survey at the end. Now let's get started. First, you are going to hear from Dr. Jan Kirschke on advanced and accelerated clinical neuro MRI. Followed by that, you'll hear from Dr. Rickmer Braren discussing 3T abdominal MRI and the benefits of the gradient strength and Compressedsense. And lastly, you'll hear from Dr. Benedikt Schwaiger, giving you insights into MSK imaging with Compressedsense. So now I welcome Dr. Jan Kirschke.
Yeah, thank you for that introduction, ladies and gentlemen. So I now want to start with clinical neuro MRI on a 3T Elation system. I don't want to make it too technically. I just want to give you a couple of insights. I first have to acknowledge that I got several grants from different entities, also from companies, and I also received honoraria from Philips Healthcare for this lecture. So we got our Elation system almost exactly 2 years back. You can see the installation procedure here, and it basically came with a new hardware, meaning mainly a new gradient coil, and it came with Compressedsense, a new software option, both leading to higher effective SNR. So what does that mean for our clinical practice? This is what I want to show you in the next couple of minutes. So basically what we're interested in neuroradiology is high image quality. So these are just two follow-up images from a patient with a resected glioblastoma. And I think just from these images, you can appreciate the difference in image quality before and after the installation of the new system. So basically, I think going back, there have been a lot of changes in MR imaging during the last, let's say, 2 or 20 years. Well, the first big advantage has been the introduction of 3 Tesla into the clinical routine. And I think now with compressed sensing, it's a little bit like now after another 10 years, now taking advantage of the SNR gain, as we now can directly translate this SNR gain into imaging speed. What does that mean for our protocols? I think you have to look at some numbers to really appreciate what's going on now. For tumor imaging, we always did a lot of 3D imaging, which tended to be very time consuming. So we had to restrict the number of acquired sequences quite substantially to stay in a clinically feasible imaging time. Now, with Compressedsense, we were able, for example, to cut down this, one of our standard protocols, which we use for preoperative tumor resection planning, of about half of the scan time, meaning that we now have only 13 minutes for preoperative planning. This is just one case example. So one case example doesn't always speak the whole truth. So what we did retrospectively is to investigate the scan time of all the sequences we acquired during 1 week before the installation of the elision and one other representative week after the installation of that system. And here you can see all the sequences that have been acquired more than 5 times during this week. And you can also appreciate that except of the SWI sequence, we had a scan time reduction of always more than 20%, in average about 30%, and for the 3D sequences of roughly 50% in scan time reduction. We not only reduced the scan time, but we also homogenized our voxel size. So meaning that for the older 3D sequences, we were not able to acquire a 1 millimeter isotropic resolution in sufficient scan time. Now with Compressedsense, we are able to acquire all the sequences with at least 1 millimeter isotropic resolution. And this adjustment is getting so much easier with Compressedsense, as there is one parameter that's easily adjustable and where you can directly influence the relationship of scan time with all the other parameters, and of course the relationship of SNR and scan time. So this is one example where in the top row you see the conventional sequence that actually has numerically speaking a little bit higher SNR compared to the other sequences, but there is no good way to really accelerate this sequence more without getting more artifacts. Then with Compressedsense, you basically have the same visual impression as with the conventional sequences, but being 2 minutes shorter. And then if we just decrease the resolution a little bit, this is a common technique to increase scan time, you can see that we have a 3-minute scan time with having the same factors. And then comes in the very kind of major advantage of Compressedsense. You just tune one factor and then you can have the same SNR as you have before. You have the same image impression, but you halve the scan time. And you can even go one step further. You can create a 1-minute sequence with a slightly lower resolution. This editing of the sequence, it just takes a couple of seconds. And then what you get afterwards is displayed here in big. Of course, the image is a little bit more blurry, but overall you have a very comparable image appearance. And from my point of view, it's still for a 1-minute 3D isotropic sequence, this is still a very high and clinically usable image quality. So this is actually the main question of our investigation before and after Compressedensing. Does the image quality change? And despite lowering the scan time, we observed in our study that the image quality was not significantly decreased in any of those scans, in any of those sequences, but we found a significant improve in overall image quality as visually assessed by 2 radiologists in at least half of the sequences as assessed by 1 radiologist. So what do you do with additional scan time, as we now know that the image quality doesn't decrease? Well, of course, you could scan more patients, but at the university hospital, it's more likely that you're more interested in doing more research and thus adding a couple of sequences, doing some more advanced stuff. That's why we now have our extended glioma protocol, where we kind of added 2 sequences, first the APT sequence and then the conventional T2 sequence. And we still able, despite adding these 2 sequences, to cut down our scan time of about 7 minutes. So these are just one example patient of our protocol, and you can nicely appreciate the high image quality of the standard sequences. And you also can see that the 3D APT signal very well corresponds to the functional imaging of the FET PET MRI. Well, for the conventional sequences, it's mainly the Compressedsense that matters with the new system, but there are a couple of examples also for Neuro MRI, where really the hardware matters. And one is epi imaging, and here you can see an example of a patient obtained with 3 different Philips systems. And of course, you can appreciate that for the new Elition system, the gradients work best, so the scan time is lowest. The duty cycles really put in their benefits. Now the shorter duty cycles lead to the shorter scan time achievable at the Elition system. What we also do a lot here at TUM is imaging of multiple sclerosis. So I brought along our standard MS protocol that also was about half an hour previously, and we could cut down this total time now of about 1/3 to roughly 20 minutes. We also were able to now acquire all the sequences in 1 millimeter isotropic resolution. And from my point of view, this is for us as an academic center, this is the greatest advantage to not only decrease scan time, but also increase the spatial resolution and make the sequences more comparable. So why is this important? First, I want to show you just some images. Again, with these examples, I think one can easily appreciate that it's not only the scan time that's reduced, but also the image quality that's due to the higher resolution is brought forward. This can also be appreciated with the DIR sequence. And with the DIR sequence, you can also see the different options you have in optimizing your sequences while using Compressedsense. You can either decrease the scan time by a factor of roughly 50%, or you can just increase the spatial resolution. And looking at the regular images, of course, it's nice to have a little bit higher resolution and for supratentorial imaging in the white matter, this doesn't matter so much. But if you go down to the cerebellum, you can appreciate the folia of the cerebellum much better with the higher resolution, as seen here in this zoomed in image. So we now, as a standard, take this high resolution images. But of course, if you do compressed sensing, and this is something what everybody knows from normal photography, from normal JPEG imaging, it may happen that the image loses something, and we were afraid of that too. So we compared the very same sequence with conventional sense acquisition and with compressed sense acquisition, half of the scan time, in 108 patients, and we were doing subtraction images between these two acquisitions to best delineate differences between these two images. And well, I can tell you, we did not miss any lesions with compressed sense. So that means that you don't have to fear that any image information disappears with compressed sensing. What we observed, that we saw some artifacts due to some small vessels in the subarachnoid space, like displayed here in the central image. These vessel artifacts were not present anymore in the acquisition with compressed sensing. This is another example of such an artifact within a small sulcus visible on the conventional DIR image, but not present anymore on the other images, including the FLAIR and the T1 TFE sequence. So overall, I really can recommend, if you have such a high resolution, high quality image protocol, that you only need to acquire 3 sequences for MS imaging, that cuts down your protocol to roughly 10 minutes. And we also recommend now, with such an high resolution, high quality protocol, to not obtain contrast enhanced imaging for MS follow-up anymore. There have been old publications that stated that with contrast, more lesions are visible. So, but with the ongoing discussions on contrast, of course, nobody wants to give too much contrast in these repeated exams in multiple sclerosis patients. So what we investigated. If you do a subtraction imaging, then you can really appreciate all the images. And this is one example with the baseline images showing on the left for one patient, the follow-up imaging in the middle. And by just visually looking at them, it's very hard now to really be sure that there is no new lesion. And then if you do a subtraction imaging, and this image on the right is done with that IntelliSpace LOBI longitudinal brain imaging software package, where new lesions are highlighted in red. And I think now with that LOBI evaluation, you can appreciate that very small red lesion adjacent to the left ventricle in the temporal horn. This lesion would probably be missed without subtraction imaging, and of course it would not necessarily take up contrast. So with this short protocol, 10-minute scan time, and now the good news comes, if you do that subtraction imaging automatically, the evaluation of such an imaging stack only takes 2 minutes. So you not only cut down the imaging time, but you also cut down the reading time. And this is, I think, very good news. And with this, I want to conclude stating that Compressedsense, of course, has the greatest advantages in all 3D sequences with a scan time reduction of up to 50%. And from my point of view, what I like a lot is the high flexibility in scan protocol design. And from the last study of those more than 100 patients, all MS lesions were visible with either higher image quality in our scan. So the we don't need that much sequences anymore, what further cuts down our scan time. Regarding the new hardware, now for most of the sequences I just showed, Compressedsense definitely is more important. But if you would go to spinal imaging, if we go to body imaging now in the following task, I think this is even more important, but also for neuro, in particular with the shorter duty cycles and the stronger gradients of the magnet, we can have a faster DTI acquisition with shorter TE that now really leads to a better imaging performance at a 70 centimeter bore compared to our previous system with a 60 centimeter bore. And this is quite amazing. And with this, I want to conclude, say thank you for your attention, and we will continue with Rickmer Braren talking about abdominal MRI.
Okay, so also welcome from my side. My name is Rickmer Braren. I'm an abdominal radiologist, and I will talk about problems that we're facing in abdominal imaging and MRI particularly, and we'll try to show you how we are using the new ELISION system to improve scan quality and also reduce scan time in the abdomen. So just to start out, I'm sure you're all aware of the problems that we're facing in abdominal imaging compared to neuro imaging or MSK, as Jan already referred to. We have various sources of motion, cardiac, diaphragmatic, intestinal, irregular breathing patterns, and all these add up to a major challenge in abdominal MRI, and is one of the reasons why CT is still one of the workhorse in abdominal imaging. We're facing highly variable anatomy and physiology. Patients have been operated on, and of course we need similar image contrast as is acquired in other body regions. So expectations are high. We want high spatial resolution also, or not only for surgical planning, but also, for example, to be sensitive in the detection of very small lesions in motion. We want robustness. Patients come back for screening. For example, patients with disease of the pancreas, like IPMN, they need regular screens. And so we want to be sure about sizes that matter in terms of making decisions for surgery or continued surveillance, for example. And of course, these patients are often highly compromised. They can hold their breath only for short times. Sometimes they suffer from ascites. And so we want to keep the overall exam short, but we also want to enable patients to hold their breath for as short period of time as possible. Jan already talked about the two main features that the new Elition system brings to us in the clinic. This is the gradient. I just want to quickly go over this. And the other component is the combination of sense and this acceleration, which is comes together in the Philips paradigm of compressed sense. And both of these in combination increase SNR efficiency and can be used to reduce scan time. More specifically, this is really of great importance in abdominal imaging. For diffusion imaging, we use an EPI sequence here, which we can then have higher SNR efficiency due to the gradients and higher resolution. Also, I will show examples of Zoom EPI, and then also especially this acceleration with sparse sampling and reconstruction in the compressed sense paradigm results in shorter scan times, shorter breath hold times, both in turbospin echo sequences and gradient echo sequences, higher spatial resolution and higher contrast in turbospin echo sequences. And this can be applied not only in 2D, but not only in 3D, but also in 2D sequences. So this is just a brief overview that visualizes the impact that both of these components have on our imaging protocols. You can see here coded in blue the sequences that really benefit from the compressed sense. In green, the ones that really enhance due to the new gradient coil, which is primarily the EPI sequence, diffusion sequence, and then ones in orange that result from both compressed sense and the new gradient coils. So we started out evaluating the system, as Jan had already told 2 years ago. We received this new Elition system, and we wanted to test, of course, how reliable imaging in the abdominal cavity could be with this compressed sense acceleration. And this is one study that we ran on the Dixon Quant, so proton density, fat fraction, and T2 star mapping. These are both functions that we often, or exams that are often required in our clinical routine. And we compared a acquisition with only sense to compressed sense. And we could show that the values are highly reliable in comparison between these two acquisitions. As you can see, we could reduce the scan time of this single breath hold sequence from 14.3 to 9.3 seconds. So this, of course, is not of such big relevance in terms of shortening the overall scan protocol, but it makes a big difference in terms of image quality, because patients can hold their breath, sometimes not for these 14 seconds. And we could show that the image quality, overall image quality or motion artifacts could be reduced by about 12 or 10% from by addition of the compressed sense factor 4. On the lower right, you see in this particular patient here, a CT scan that shows differences in fat infiltration in the liver, which are nicely recapitulated in the MR image. Okay, another area that most of you are familiar with and a sequence that you use a lot is an MRCP sequence. This is a common question in liver pathology and pancreatic pathology. We started out at our site before the introduction of the Elition system. We ran most of our abdominal scans actually at 1.5 Tesla due to the robustness of the imaging. And I'm sure this is still in place in many sites outside the university environment. So we wanted to compare a common 2D single shot acquisition protocol with our 3D acquisitions that we ran on the Elition. And here we compared two different settings. One is a respiratory triggered sequence with a compressed sense factor of 10. And the other one was a 3D single breath hold sequence with a very high acceleration factor of 24. And on the left-hand side, you can see the respective imaging times, acquisition times, and you can see that the single breath hold sequence actually allows acquisition of the entire 3D block at a fairly high resolution at 17.5 seconds. We wanted to quantify or more quantitatively evaluate the quality of this imaging, and what you can see here is the line profile plotted across major ductal structures. And you can tell, of course, the single shot acquisition has a fairly sharp line profile indicated by this steep incline, similar to the single breath hold 3D acquisition, which is slightly more blurry in this 3D respiratory triggered data set. But nevertheless, you have very high image quality in both 3D acquisitions. And you have the possibility to reconstruct these images later on. So for patients that cannot hold their breath, even for a single breath hold for 17 seconds, we have additional protocols. And you can tell here in these fine ductal structures, of course, you lose signal when you go down to a 7-second breath hold. But oftentimes in my clinical practice, clinicians just want to rule out major pathologies. And in such cases, such a protocol that includes a 7-second acquisition of the entire biliary and pancreatic structure or ductal structures is very, very useful. Okay, as I said, reconstruction is a big issue. Just an example here. So this is from the 3D acquisition, respiratory triggered acquisition, which we get in 3.5 minutes, acquired with compressed sense factor of 10. And you can nicely tell that post-acquisition reconstruction, any plane is possible. You can see the pancreatico-jejunostomy, as well as the biliodigestive anastomosis here nicely reconstructed. Alison already introduced briefly introduced the new Vital Eye system, which we apply also in the abdominal cavity. And this really has improved our imaging protocols as well. So traditionally, these sequences are acquired with a respiratory belt that needs to be put on by the technician, and it needs to be positioned, sometimes repositioned, if it doesn't generate a nice triggering curve. And here you can see, and we evaluated this also in a prospective study where we scanned patients with both respiratory belt and the camera subsequently, and we could show that this really results in higher SNR, less incorrect triggering, and this was due to a more homogeneous amplitude of the acquisition signal with a very high or reduced blurring of the ductal structures. Okay, so now I want to switch fields a little bit. This is part of our research here at the university side. Of course, we're interested in pushing further into the exploitation of imaging data. And this is some work showing the differentiation of different subtypes in pancreatic cancer, which are shown in this middle block of images. Different types of pancreatic cancer can be detected by immunohistochemical staining, and you all are familiar with these advances in machine learning and radiomics, which tries to extract such information from imaging data. And we've trained models so far to differentiate such subtypes from preoperative imaging, and our goal is to further enhance these algorithms. And for that, we need high resolution, or this is one reason why we're very much interested in high resolution motion or motionless imaging of the abdomen. And so in diffusion imaging, which is a particularly promising technique for the development of such models because it doesn't require external contrast injection and has some functional information, we've tested this compared to our old 3T Ingenia system, and I just want to show you this little table showing what we can reach with the addition of the elision in the enhanced gradient mode. We can reduce the scan time compared to our previous system by 33%, as you can see here, keeping TR and TE similar. And this then results, when you compare the Ingenia enhanced mode with the elision enhanced mode, in comparable SNR, yet a increase in SNR efficiency by about 20%. And so this is one comparison just in a case of a 70-year-old patient with a side branch IPMN that developed a small nodule. And you can see on the left image in the ultrasound, this nodular structure is something that is important to identify, as it may represent the formation of pancreatic cancer inside these pre-cancerous lesions. And you can nicely see in this full field of view B600 image, the high intensity nodule. Of course, Jan already talked about this. At the university side, we're interested in pushing these limits, increasing resolution to provide even higher image quality and higher confidence in the detection of such small lesions. And here shown in these inverted B images, the B600 on the left-hand side and the B1000 image. On the right-hand side, with a higher resolution, we're able to detect smaller lesions that we otherwise would have missed. In this case, for sure, a small neuroendocrine tumor that was resected, and such lesions we're now able to detect routinely, not only in the pancreas, but also in the liver in case of, for example, pancreatic cancer, where small lesions determine the path between palliative treatment currently and potentially curative resection. The B1000 image is something that we now routinely acquire, especially in these patients that come for surveillance with a side branch IPMN, and with this lesion in the pancreatic head, you can nicely see how the B1000 image provides complete suppression of the T2 shine through effect, and this provides higher confidence in the evaluation of such lesions in routine imaging. This is a nice example how we use Compressedsense in the pelvic region for rectal cancer staging. So with a Compressedsense factor of 7.5, we now acquire a 3D data set, and this allows post-acquisition reformatting in any particular plane. And this patient, for example, was staged by our endoscopists as a tumor that could be resected endoscopically by endoscopy, and clearly visualized on the upper right image, upper right corner panel of the parasagittal, paracoronal imaging. You can see that this tumor is transmural. There is vascular invasion of these small veins seen right adjacent to the wall, and therefore clearly indicates resection by surgery. There's another example here of a patient where we pushed this resolution even further in the beginning when we tested this system. So even up to 0.8 millimeter isotropic data sets can be generated. Of course, at this point, it is not clear how this very high resolution is going to add in terms of diagnostic confidence or predictive value when combined with algorithms as just shown for the diffusion imaging that we are currently working on. Okay, so I hope I gave you a short overview of the imaging in the abdominal cavity and how we're using this new system to improve image quality, diagnostic confidence, and also be able to use this in a quantitative or semi-quantitative manner. With this, I would like to hand over to my colleague, Benedikt Schwaiger, who's going to talk about the new system and its usage in MSK.
Yeah, thank you very much, and a very warm welcome from my side as well to this third part of our webinar. And my name is Benedikt Schwaiger. I'm focusing on MSK imaging, and this is what I'm going to talk about. Of course, I have to acknowledge that I received a honorarium from Philips for this talk as well. So what I would like to talk about are these three topics. First of all, I want to talk about reducing examination time with the new technology. Secondly, I would like to give some insights on optimizing resolution and signal-to-noise ratio. And the third part will tell you a little bit about what we're trying to establish as new applications for MR imaging in MSK with Compressedsense. And let's start with the examination time. We heard about that before. It's of course very important. This is always a critical issue for several reasons, for patient compliance, but also with a view to financial issues. And as we heard in the previous talks, it's quite easy or quite promising to reduce examination time if you use 3D sequences with Compressedsense in comparison to sequences without. But if you are looking at joint structures or other MSK applications, there's still a regular use of 2D sequences if you're looking at very thin structures such as joint cartilage, or if you want to adequately assess the signal behavior of ligaments, you're still using 2D sequences a lot. So this is something I would like to talk about first, and this will be based on a publication we did on ankle imaging, and then secondly, I'll show you some examples of what you can do with 3D imaging, which is accelerated with Compressedsense. So let's look at the 2D sequences first. This is a study we did with our routine clinical protocol comprising 2D sequences. These are actual 2D sequences with a voxel size of 0.15 by 0.28 by 2 millimeters. And to the left, you see sequences that have sense, but not Compressedsense. Those are shown to the right. And if you just look at these images and compare them side by side, looking at the tendons, you see there the muscles, also the trabecular structure, which is not of high interest in this context, but maybe illustrative. You don't really see much of a difference there. And this is another example from the same study. Left again, sense only, and to the right it's Compressedsense. And again, I'm really not able to tell any difference regarding image quality there. And we looked at this in 20 ankles. We used, as I said, our routine clinical protocol, and we assessed joint structures of the ankle using Likert scales or semi-quantitative scales for image quality. And we also did signal-to-noise and contrast-to-noise measurements. And the results were very promising. We found a substantial to perfect agreement for image quality, and SNR and CNR of images with Compressedsense even tended to be higher. And this alone is not that interesting, but the most, or the key finding here is that we were able to reduce the total acquisition time of the protocol by 20% of this protocol comprising only 2D sequences. And this is quite relevant for the individual patient, but also in the end of the day, you can just examine more patients. And that's, I think, a very relevant issue. So let's have a look at 3D here. Compressedsense allows for shortened ETL, so echo train lengths. This reduces blurring. So on one side, allows for higher spatial resolution, but on the other hand, oh, sorry, I forgot this one. If you're using isotropic resolution, this is very interesting as well because it allows you reformatting in any arbitrary plane. And I have a very nice example for this in a second. And yeah, you have the reduced examination time, of course, but you have to take care and be aware of the fact that 3D is not 2D if you're looking at tissue contrast. And this is very important if you're looking at ligaments, at cartilage, at bone marrow. So these are examples. To the left, this is a 2D sequence taken from our routine clinical protocol, which I think has a very nice tissue contrast if you're looking at this bone marrow edema here, at the subchondral insufficiency fracture we just saw, but also if you're looking at the joint cartilage, the menisci, and the anterior cruciate ligament, I think these are very nice images. And to the right, starting now, hopefully, yes. So this is the 3D equivalent of the sequence, and you see it has a very, very nice and high isotropic resolution of 0.34 millimeters. But just have a look at the anterior cruciate ligament. There it is. You see it's just a signal behavior which is different from the 2D sequence you may be used to. So just keep that in mind. But one of the huge advantages is that it allows you to do new reformats. This is something which is quite new to us as well, but I think this is very fascinating, very promising for clinical applications. So this is a radial reformation, and you can use this for assessing the menisci. So if you're looking at menisci pathologies, you often have a three-dimensional pathology, and really to understand this, I think this is very useful. So this is definitely something we are going to use in the future in the clinical context. Okay, so the second part of my talk is about resolution and signal-to-noise ratio. There are two examples for that. One is MSK tumors. As you may be well aware of, it's very important regarding preoperative imaging that we are able to tell the surgeons about surgical margins, about the context of surrounding structures, and for that we need a high resolution. And hip imaging, as an example, for a region which is very hard to image still, differentiating acetabular and femoral cartilage, for example, and also the labrum, you really want to have a high resolution there. And Compressedsense can do that for you. You can get a higher spatial resolution, as shown before, in the same scan time. So let's have a look at two examples. One is a very rare tumor, an alveolar soft tissue or soft part sarcoma after biopsy, and the other one is a sagittal hip with a cartilage defects in labrum. So this is the first example. This is, again, a 2D sequence with a voxel size in-plane resolution of 0.2 millimeters. And there you see it in the vastus lateralis. It will show up in a second again. You see the tumor and also the biopsy canal very nicely. You can differentiate it very well from the surrounding tissue. And if you show this to your orthopedic surgeons, they'll be very happy about the information in this image. This is another example from the same patient. This is a T1 fat set image after contrast. And here you can clearly differentiate the solid tumor from the reaction in the surrounding muscle, the vastus lateralis. And my second example is the hip. This is an example how you can actually differentiate the acetabular and the femoral cartilage from each other, and how you can tell the anterior labrum and the degenerated labrum. There was performed surgery on that before, but I think this is a very promising approach to hip imaging. Okay, and as my third topic in MSK imaging, I would like to present to you a couple of new applications. And just to give you a background very briefly, most MSK pathologies, as you well know, consist of a soft tissue component and a bony component. And therefore, patients regularly undergo MR and CT or radiographs at the same time. And you have a couple of, and this is of course associated with examination time, additional examination time and radiation doses. But there are a couple of patient collectives where you don't want that. For example, in young patients with MSK tumors, radiation doses, of course, are critical. And therefore, we asked ourselves the question, is there any way we can replace CT or radiographs in the future by using specific MR sequences? And our approach to this is using a high resolution 3D T1 weighted gradient echo sequence. And what we do is we basically invert the grayscale, and we can also simulate projected radiographs based on that. And these are examples. This is a Ewing sarcoma of the ulna in a very young patient. To the left, there's the radiograph where you see this permeative destruction pattern and this complex periostal reaction with the Codman triangle and the sunburst phenomenon. And this is everything, all this information is in the image to the right as well. And this one is based on MSK, on MR imaging on this T1 gradient echo sequence. And this is another application of a benign bony lesion. It's really hard to tell where it is. In the conventional radiograph, you can see it a lot better. In the middle image, this is one of these virtual radiographs based on MR imaging, where you see this lobulated structure and the matrix mineralization. And in the simulated CT on the right, you see it quite nicely. Again, these are reformations of the same sequence, and this is an enchondroma, and this is very obvious from these images. So I think this is a very nice example as well. And yeah, we looked at this in 32 subjects with benign and malignant bone lesions, and we found that we compared periostal reaction, matrix mineralization, and destruction pattern, and we found again a substantial to perfect agreement between MR-derived images and original CT or radiograph images, of course, with additional information on soft tissue extension, and therefore we were able to enhance our diagnostic confidence. So we think this may replace radiographs or CT for certain diagnosis in the future. And why is this relevant in the context of a newer hardware? Well, if we acquire this sequence on the Elition, this has several advantages. First, we can substantially accelerate 3D sequences with Compressedsense, and therefore the sequence just goes down regarding examination time. And thanks to the improved gradient duty cycle of the coil, we have shorter TRs compared to older scanners, and this of course also positively affects examination times. We want to apply this sequence to the spine. We just had a presentation, and this paper is currently undergoing review, so you'll find this in the literature very soon. And also the shoulder, I showed you a couple of examples, or I brought you a couple of examples here. We have a lot of young patients with anterior shoulder instability, and if you want to differentiate on-track and off-track lesions, you can do this very easily by just using this sequence, and also other measurements in the bony structures of the shoulder just work fine. For example, if you want to know about the glenoid version and the bone stock measurements, those work very well as well. So let's sum this up. Compressedsense and MSK imaging may be used either to reduce acquisition time compared to sequences without Compressedsense, and with stable image quality, both in 2D, as I showed you, and 3D acquisitions, as we heard before, or it may be used to increase spatial resolution. And therefore, it allows us to apply new sequences in regions that were previously very difficult to examine. Let me just add in the very end that the priorities depend very much on the individual case. As Dr. Kirschke said before, you really have a high flexibility here regarding the application, and you really have to find out yourself what you want to do with it. But what we've done so far in MSK imaging was very promising. Thank you very much.
Okay. Thank you, Dr. Kirschke, Dr. Braren, and Dr. Schwaiger for this informative webinar. We do have a little bit of time for some questions. So Dr. Kirschke, I would like to start with you. A question from the audience. So you only showed Compressedsense in the brain. Can it also be used in the spine, and what is your experience there?
Yeah, so we started off with the brain because it's a little bit easier in the brain to be implemented and to be used. In the spine, it can be used as well. The advantages in the spine are probably not as high as in the brain if we stay with 2D sequences. One major advantage at the spine, or in particular at the lumbar spine, is that if you switch to 3D imaging with a slightly sub 1 millimeter isotropic spatial resolution, there's been one study from Cologne that showed this, that you won't miss a relevant clinical finding by using such a sequence that just takes 5 minutes and basically covers all the planes and all the possible reformations. So we haven't investigated 3D imaging in the spine a lot, but there's this really one good paper out that showed its feasibility, and you basically can cut down your exam time for a lumbar scan down to 5 minutes using one 3D sequence with Compressedsense. So if you're using 2D sequences at the spine, as we started with the new system, we had the release 5.4. With this release, it was still a little bit tricky as we observed some artifacts due to the calibration technique of the Compressedsense. These artifacts now vanished with the release 5.6, but there I think we definitely have to invest a little bit more time to further optimize these protocols. But in general, now we're using that for multiple sclerosis imaging of the myelin. We already, without much looking into protocol details, we save about 20% of the scan time using Compressedsense for myelin imaging.
Great. That actually leads me to the next question that we have from one of our customers, and that is, do you also do 2D images in the brain with Compressedsense?
Yeah, definitely. So as I showed in the most used imaging sequences during the 2 weeks of comparison, about half of these sequences were 2D sequences, in particular like conventional 2D T2 TSE sequences. We still do. We really cut down our 2D flare images because like 3 minutes for a 2D flare and 4 minutes for a 3D flare. From our point of view, it's better to really make always the same images, have a better comparability between patients and so on. So we really cut down our usage of 2D flare. But of course, almost all of our 2D images of the brain are currently also accelerated with Compressedsense. And
Great.
yeah, one more comment. With 2D images, the only difference probably is that the acceleration that we gain is about 50% in 3D imaging and about 20 to 30% in 2D imaging.